So, good afternoon, distinguished colleagues, ladies and gentlemen. Thank you for the opportunity to present my work. My name is Job Karoe, and on behalf of my co-authors, Dr. Josephine Masharia, Dr. Agatha Kehi, Winfred Oboy, and Dr. Naomi Gashara, I'm honored to present our study entitled Clinical Spectrum and Outcomes of Pediatric Cardiac Disease in Nyeri, Kenya. Now in Kenya, most published pediatric cardiac data come from tertiary referral centers. However, much less is known about the children seen in regional specialist clinic, like in our case, the clinic at Nyeri. Our objective was understanding who these children are, the conditions they present with, and what happens to them after diagnosis. We also wanted to identify gaps in the care pathway and to provide evidence to guide service planning for the Mount Kenya region and other similar resource-limited settings. Now, with that background, let's look at how we studied this population. Now, this was a retrospective study covering 2 years of clinical practice. We reviewed children who had attended pediatric cardiac clinics, initially held at Neleon Doctors Plaza before transitioning to Karen Hospital in Nyeri. And to improve data quality, only children with confirmed cardiac pathology were included. Patient information from paper records was systematically digitized into a standardized database for analysis. Following exclusion of normal echocardiograms and incomplete records, we obtained 157 analytical cohort representing confirmed cardiac disease. Now, one of the most striking finding was the geographical reach of this clinic. We had children traveling from 9 counties. And of note, more than half of our patients came from outside Nyeri County. Now, this demonstrates that the clinic is serving much more than a local population. It has become a regional referral hub for the wider Mount Kenya region. It also highlights the scarcity of specialized pediatric cardiac services outside major urban centers. Now, out of the 157 cohort, a majority presented with congenital heart disease. The median age at presentation was just 10 months, highlighting that many children are being identified during infancy. We also found from our study that it was 1.5 times commoner in females than males to have cardiac disease. Interestingly, children with congenital heart diseases presented earlier than those with acquired cardiac disease. Now, this reflects the success of frontline healthcare workers in recognizing symptomatic congenital lesions earlier on. Now, looking more closely at the spectrum of disease, we found that septal defects formed a significant portion of the congenital lesions, which was consistent with the global experience. However, what stood out in our cohort was the substantial burden of dilated cardiomyopathy, which requires, as we know, prolonged medical follow-up. These children often require repeated clinic visits, multiple medications, and continuous monitoring, placing a strain on families living far from specialized centers. And now we then asked ourselves one critical question: which conditions drive the poorest outcomes in our cohort? Now, first, we found out that 1 in 5 children with cardiac disease died. Now, complex cyanotic heart disease had the highest mortality among the congenital heart diseases, while pericardial disease was the leading cause of death among the acquired heart diseases. The key message being, not all diagnoses carry the same risk. Nevertheless, identifying high-risk patients is only the first step. And the next question is whether they reach definitive treatment in time. Now, diagnosis offers hope, but not a cure. Identifying high-risk children is usually only the first step. The next challenge is ensuring they reach definitive treatment. Now, as you can see, nearly 90% of children requiring catheter-based interventions underwent the procedure. Yet, more than half needing cardiac surgery never got the surgery done. Now, for most families, the limiting factor was not the diagnosis, but access, with financial constraints cited by 60% of the families. Now, this slide here holds the most important message from our study. It demonstrates a 5 times more mortality when a planned intervention was not done. Even if these children entered the cardiac care system, far fewer completed the journey to definitive intervention. The figure fundamentally changes the question from how do we diagnose more children to how do we ensure every diagnosed child reaches definitive treatment. Now, 4 important messages emerge from these findings. Our findings demonstrate that regional pediatric cardiac clinics can substantially improve access to specialist services by extending the service closer to the communities where these children live. A particularly encouraging finding was the relatively young median age at presentation. However, this advantage is lost when it comes to accessing definitive treatment. These findings suggest that the major challenge has shifted from diagnosing children with heart disease to ensuring that they can access the treatment they need. Finally, our study highlights the significant burden of myocardial disease, particularly so dilated cardiomyopathy, which demonstrates an early infant segment of cardiac failure and requires expensive and extensive multidisciplinary team management. Now, based on our findings, we propose 5 key recommendations. First, as we've been hearing all around the conference, we need to expand share coverage to comprehensively support pediatric cardiac surgery, catheter-based interventions, and management of heart failure in children. Second, an integrated national pediatric cardiac registry would allow patients to be tracked seamlessly from diagnosis through intervention. Third, we recommend that we have dedicated pediatric cardiac coordinators whose role would be in guiding families through the referral process and ensuring continuity of care. Fourth, children with high-risk conditions should be prioritized through expedited referral pathways, ensuring they received timely interventions before preventable deterioration occurs. Finally, our findings support strengthening of regional pediatric cardiac networks through outreach clinics, through telemedicine, and also through creation of standardized referral pathways. Thank you very much for your time.
Thank you very much.